Hi, everybody. Thanks so much. My name is Aaron Goldberg. I'm a leukemia physician at Sloan Kettering Cancer Center in New York City. It's a pleasure to talk with you today about acute myeloid leukemia and some updates from our European Hematology Association annual meeting. So, in acute myeloid leukemia, it's a serious blood cancer, but outcomes have been getting better and better. And in particular, I want to talk about the use of a drug called Venetoclax, which has really improved outcomes in our adults with acute myeloid leukemia who are older. The median age is about 68 years old, and also for patients who are not fit, who might be younger but not fit to receive intensive chemotherapy. So we've known for a while from clinical trial data that this can provide a very good treatment option for our patients. About 2/3 of the patients can achieve remissions with this combination. But what we want to look at actually is how does this combination work now in the real world outside of the clinical trial setting. And so we wanted to see, number one, how do you manage the drug? What do we do with patients? How do we get them into remission? And then what are the different medications that we use to keep them in remission? And how do we dose the medication? And what are the effects that the different medications that we use have on that dosing? And then we also want to look at what's the impact on what we call healthcare resource utilization. Historically, acute myeloid leukemia has been a disease that was treated largely, with intensive chemotherapy, and that's mostly in the inpatient hospital setting. And I think one of the advantages of this newer regimen is that we're now able to give this highly effective treatment that's much more outside the hospital and much more in the clinic. So for this first, real world evidence initiative, we partnered with a bunch of centers. There are 17 sites around the world to just collect our data to see how are our patients doing with acute myeloid leukemia. And again, what we saw, first is that it's similar to the clinical trial data. About 2/3 of our patients are able to achieve these remissions. And then we focus, really closely on those patients who achieve remissions. And we ask some questions about, how long these remissions last. What are the different medicines that patients are on? Does it affect the dosing of venetoclax? Does it matter if we take breaks, for example? And so one of the things that we found is that it is okay and actually even important to take a short break after each treatment cycle to allow the blood cell counts to recover. So that's, I think, also from a patient perspective, we're not really giving the venetoclax drug as an oral pill every day. We're giving it maybe initially for 28 days in a row, and then with later rounds or cycles of treatment, we shorten it to 21 or even 14 days of treatment and allow some time for count recovery. And the other agent is this azacitidine given IV, or decitabine also given IV for the first 5 or 7 days. And what we found is that it's okay to take those breaks, and actually we should take those breaks, but we also don't want to wait too long. We did find that if we waited for more than 15 days between cycles, there was a trend towards patients maybe having a shorter period of time where their disease was under control and remission. So I do think that was one of the take-homes, was that we should take those breaks to allow blood count recovery, but not necessarily wait forever for blood count recovery. In terms of other medicines, we found that it was okay to give medicines like growth factors in the setting of remission. There didn't seem to be any impact upon how patients did with that. So that was a helpful lesson to learn. And also antifungals. So antifungal use is very important to try to reduce the risk of infections in our patients. And we found that that seemed to be okay. There was no impact on the duration of how long patients were in remission. Thank you so much.